Normal impulse conduction. Sinoatrial node. Avenue node. Bundle of His. Bundle branches. Purkinje fibers. The normal conduction system. What is an EKG? The electrocardiogram, EKG, is a representation of the electrical events of the cardiac cycle. What types of pathology can we identify and study from EKGs? Arrhythmias. Myocardial ischemia and infarction. Pericarditis. Chamber hypertrophy. Electrolyte disturbances, i.e. hypokalemia, hypokalemia. Drug toxicity, i.e. digoxin and drugs which prolong the QT interval. Waveforms and intervals. Impulse conduction and the ECG. Sinoatrial node. Avenue node. Bundle of His. Bundle branches. Purkinje fibers. The PQRS-TP wave, atrial depolarization. QRS, ventricular depolarization. T wave, ventricular repolarization. Atrial depolarization. The PR interval. Atrial depolarization. Plus. Delay in avenue junction. Avenue node/bundle of His. Delay allows time for the atria to contract before the ventricles contract, pacemakers of the heart. SA node, dominant pacemaker with an intrinsic rate of 60 to 100 beats/minute. Avenue node, backup pacemaker with an intrinsic rate of 40 to 60 beats/minute. Ventricular cells, backup pacemaker with an intrinsic rate of 20 to 45 bpm. The ECG paper horizontally vertically one small box, 0.04 s. One large box, 0.20 s. Vertically. One large box, half a millivolt. EKG leads. Leads are electrodes which measure the difference in electrical potential between either 1. Two different points on the body, bipolar leads. 2. One point on the body and a virtual reference point with zero electrical potential, located in the center of the heart, unipolar leads. EKG leads. The standard EKG has 12 leads, 3 standard limb leads, 3 augmented limb leads, 6 precordial leads. The axis of a particular lead represents the viewpoint from which it looks at the heart. Rhythm analysis. Step 1. Calculate rate. Step 2. Determine axis. Step 3. Determine regularity. Step 4. Assess the P waves. Step 5. Determine PR interval. Step 6. Determine QRS duration. Standard limb leads. Standard limb leads. Augmented limb leads. All limb leads. Precordial leads. Precordial leads. AV, augmented limb leads. Summary of leads. Limb leads. Precordial leads. Bipolar. 1, 2, 3. Standard limb leads. Dash. Unipolar. AV, augmented limb leads. V1 V6. Anatomic groups, septum. Anatomic groups, anterior wall. Anatomic groups, lateral wall. Anatomic groups, inferior wall. Anatomic groups, summary. Rule of 300. Take the number of big boxes between neighboring QRS complexes, and divide this into 300. The result will be approximately equal to the rate. What is the heart rate? www.aptodate.com 300 6 equals 50 bpm. What is the heart rate? www.uptodate.com. 300, 4 equals 75 bpm. What is the heart rate? 300, 1.5 equals 200 bpm. The rule of 300. It may be easiest to memorize the following table. Hash of big boxes. Rate 1, 300, 2, 150, 3, 100, 4, 75, 5, 60, 6, 50. 10-second rule. As most EKGs record 10 seconds of rhythm per page, one can simply count the number of beats present on the EKG and multiply by 6 to get the number of beats per 60 seconds. This method works well for irregular rhythms. What is the heart rate? 33 by 6 equals 198 bpm. The Allen Elanzi ECG Learning Center, http://medistat.med.utah.edu/kw/ig/ 33 by 6 equals 198 bpm. The QRS axis. The QRS axis represents the net overall direction of the heart's electrical activity. Abnormalities of axis can hint at ventricular enlargement, conduction blocks, i.e. hemiblocks, the QRS axis. By near consensus, the normal QRS axis is defined as ranging from -30 degrees to +90 degrees. -30 degrees to -90 degrees is referred to as a left axis deviation, LAD. +90 degrees to +180 degrees is referred to as a right axis deviation, RAD. Determining the axis. The quadrant approach. The equiphasic approach, determining the axis predominantly positive, predominantly negative. Equiphasic. The quadrant approach. 1. Examine the QRS complex in leads I and F to determine if they are predominantly positive or predominantly negative. The combination should place the axis into one of the 4 quadrants below. The quadrant approach. 2. In the event that LAD is present, examine lead 2 to determine if this deviation is pathologic. If the QRS in 2 is predominantly positive, the LAD is non-pathologic, in other words, the axis is normal. If it is predominantly negative, it is pathologic. Quadrant approach. Example 1. The Allen Elanzi ECG Learning Center, http://medistat.med.utah.edu/kw/ig/ Negative in I, positive in AVFRAD. Quadrant approach. Example 2. The Allen Elanzi ECG Learning Center, http://medistat.med.utah.edu/kw/ig/ Positive in I, negative in AV, predominantly positive in 2. Normal axis, non-pathologic LAD. The equiphasic approach. 1. Determine which lead contains the most equiphasic QRS complex. The fact that the QRS complex in this lead is equally positive and negative indicates that the net electrical vector, i.e. overall QRS axis, is perpendicular to the axis of this particular lead. 2. Examine the QRS complex in whichever lead lies 90 degrees away from the lead identified in step 1. If the QRS complex in this second lead is predominantly positive, then the axis of this lead is approximately the same as the net QRS axis. If the QRS complex is predominantly negative, then the net QRS axis lies 180 degrees from the axis of this lead. Equiphasic approach. Example 1. The Allen Elanzi ECG Learning Center, http://medistat.med.utah.edu/kw/ig/ Equiphasic in AV, predominantly positive in I, QRS axis 0 degrees. Equiphasic approach. Example 2. The Allen Elanzi ECG Learning Center, http://medistat.med.utah.edu/kw/ig/ Equiphasic in 2 predominantly negative in navel QRS axis plus 150 degrees. Step 2. Determine regularity. Look at the RR distances, using a caliper or markings on a pen or paper. Regular, are they equidistant apart? Occasionally irregular. Regularly irregular. Irregularly irregular. Interpretation. Regular. Step 3. Assess the P waves. Are there P waves? Do the P waves all look alike? Do the P waves occur at a regular rate? Is there one P wave before each QRS? Interpretation. Normal P waves with one P wave for every QRS. Step 4. Determine PR interval. Normal, 0.12 to 0.20 seconds. 3 to 5 boxes. Interpretation. 0.12 seconds. Step 5. QRS duration normal, 0.04 to 0.12 seconds. 1 to 3 boxes. Interpretation. 0.08 seconds. Rhythm summary normal sinus rhythm rate 90 to 95 BPM regularity regular. P waves normal. PR interval 0.12 s. QRS duration 0.08 s. Interpretation. Normal sinus rhythm. The QRS complex with interval and segment measurements. ECG paper unrelated heart rate and voltage computations. Arrhythmia formation. Arrhythmias can arise from problems in the sinus node, atrial cells, avenue junction, ventricular cells. SAR node problems. The SAR node can fire too slow, fire too fast. Sinus bradycardia, sinus tachycardia. Sinus tachycardia may be inappropriate response to stress. Atrial cell problems. Atrial cells can fire occasionally from a focus. Fire continuously due to a looping re-entrance circuit. Premature atrial contractions, PACs. Atrial flutter. Avenue junctional problems. The avenue junction can fire continuously due to a looping re-entrance circuit. Block impulses coming from the SAR node. Paroxysmal supraventricular tachycardia. Avenue junctional blocks. Rhythm number 1 rate, 30 BPM regularity. Regular P waves, normal. PR interval, 0.12 s. QRS duration, 0.10 s. Interpretation. Sinus bradycardia. Rhythm number 2 rate, 130 BPM regularity. Regular P waves, normal. PR interval, 0.16 s. QRS duration, 0.08 s. Interpretation. Sinus tachycardia. Premature beats. Premature atrial contractions, PACs. Premature ventricular contractions, PVCs. Rhythm number 3 rate, 70 BPM regularity. Occasionally irreg. P waves. 2/7 different contour. PR interval, 0.14 s, except 2/7. QRS duration, 0.08 s. Interpretation. NSR with premature atrial contractions. Premature atrial contractions. Deviation from NSR. These ectopic beats originate in the atria, but not in the SAR node, therefore the contour of the P wave, the PR interval, and the timing are different than a normally generated pulse from the SAR node. Rhythm number 4 rate, 60 BPM regularity. Occasionally irreg. P waves. None for 7th QRS. PR interval, 0.14 s. QRS duration, 0.08 s, 7th wide. Interpretation. Sinus rhythm with 1 PVC. Ventricular conduction. Normal. Signal moves rapidly through the ventricles. Abnormal. Signal moves slowly through the ventricles. Avenue nodal blocks. First degree avenue block. Second degree avenue block, type I. Second degree avenue block, type 2. Third degree avenue block. Rhythm number 10. Rate 60 bpm. Regularity regular P waves. Normal. Peer interval 0.36 s. QRS duration 0.08 s. Interpretation. First degree avenue block. First degree avenue block. Etiology: prolonged conduction delay in the avenue node or bundle of His. Rhythm number 11. Rate 50 bpm. Regularity regularly irregular P waves. NL, but fourth no QRS. Peer interval lengthens. QRS duration 0.08 s. Interpretation. Second degree avenue block, type I. Rhythm number 12. Rate 40 bpm. Regularity regular P waves. NL, 2 of 3 no QRS. Peer interval 0.14 s. QRS duration 0.08 s. Interpretation. Second degree avenue block, type 2. Second degree avenue block, type 2. Deviation from NSR. Occasional P waves are completely blocked, P wave not followed by QRS. Rhythm number 13. Rate 40 bpm. Regularity regular P waves. No relation to QRS. Peer interval none. QRS duration wide, greater than 0.12 s. Interpretation. Third degree avenue block. Third degree avenue block. Deviation from NSR. The P waves are completely blocked in the avenue junction. QRS complexes originate independently from below the junction. Supraventricular arrhythmias. Atrial fibrillation. Atrial flutter. Paroxysmal supraventricular tachycardia. Rhythm number 5. Rate 100 bpm. Regularity irregularly irregular P waves. None. Peer interval none. QRS duration 0.06 s. Interpretation. Atrial fibrillation. Atrial fibrillation. Deviation from NSR. No organized atrial depolarization, so no normal P waves. Impulses are not originating from the sinus node. Atrial activity is chaotic, resulting in an irregularly irregular rate. Common affects 2 to 4%, up to 5 to 10% if greater than 80 years old. Rhythm number 6. Rate 70 bpm. Regularity regular P waves, flutter waves. Peer interval none. QRS duration 0.06 s. Interpretation. Atrial flutter. Rhythm number 7. Rate 74 148 bpm. Regularity regular P waves. Normal none. Peer interval 0.16 s. None. QRS duration 0.08 s. Interpretation. Paroxysmal supraventricular tachycardia, PSVT. PSVT. Deviation from NSR. The heart rate suddenly speeds up, often triggered by a PAC, not seen here, and the P waves are lost. Ventricular arrhythmias. Ventricular tachycardia. Ventricular fibrillation. Rhythm number 8. Rate 160 bpm. Regularity regular P waves. None. PR interval. QRS duration wide, greater than 0.12 seconds. Interpretation. Ventricular tachycardia. Ventricular tachycardia. Deviation from NSR. Impulse is originating in the ventricles, no P waves, wide QRS. Rhythm number 9. Rate, none. Regularity, irregularly. Irreg. P waves, none. Peer interval, none. QRS duration, wide, if recognizable. Interpretation, ventricular fibrillation. Ventricular fibrillation. Deviation from NSR, completely abnormal. Diagnosing a ME. To diagnose a myocardial infarction, you need to go beyond looking at a rhythm strip and obtain a 12-lead ECG. 12-lead ECG. Rhythm strip, Saint elevation. One way to diagnose an acute ME is to look for elevation of the Saint segment. Saint elevation, cont. Elevation of the Saint segment, greater than one small box, in 2 leads is consistent with a myocardial infarction. Now, where do you think this person is having a myocardial infarction? Inferior wall ME. This is an inferior ME. Note the Saint elevation in leads 2, 3 and AV. How about now? Anterolateral ME. This person's ME involves both the anterior wall, V2 V4, and the lateral wall, V5 V6, I, and AV. Right atrial enlargement. Right atrial enlargement. Take a look at the CCG. What do you notice about the P waves? The P waves are tall, especially in leads 2, 3 and AV. Ouch! They would hurt to sit on. Right atrial enlargement. To diagnose RA, you can use the following criteria. 2P greater than 2.5 mm, or V1 or V2P greater than 1.5 mm. Greater than 1.5 boxes, in height. Remember, one small box in height equals 1 mm. Greater than 2.5 boxes, in height. A cause of RA is RVH from pulmonary hypertension. Left atrial enlargement. Take a look at the CCG. What do you notice about the P waves? Notched. Negative deflection. The P waves in lead 2 are notched, and in lead V1 they have a deep and wide negative component. Left atrial enlargement. To diagnose LA, you can use the following criteria. 2 greater than 0.04 s, 1 box, between notched peaks, or V1 neg. Deflection greater than 1 box wide x 1 box deep. Normal. LA. A common cause of LA is LVH from hypertension. Left ventricular hypertrophy. Compare these two 12-lead ECGs. What stands out as different with the second one? The QRS complexes are very tall, increased voltage. Normal. Left ventricular hypertrophy. Answer. Left ventricular hypertrophy. Criteria exist to diagnose LVH using a 12-lead ECG. For example, the R wave in V5 or V6 plus the S wave in V1 or V2 exceeds 35 mm. Right ventricular hypertrophy. Take a look at the CCG. What do you notice about the axis and QRS complexes over the right ventricle, V1, V2? There is right axis deviation, negative in I, positive in 2, and there are tall R waves in V1, V2. Right ventricular hypertrophy. To diagnose RVH, you can use the following criteria. Right axis deviation, and V1 R wave greater than 7 mm tall. A common cause of RVH is left heart failure. Right ventricular hypertrophy. Compare the R waves in V1, V2 from a normal ECG and one from a person with RVH. Notice the R wave is normally small in V1, V2 because the right ventricle does not have a lot of muscle mass. But in the hypertrophied right ventricle the R wave is tall in V1, V2. Normal. RVH, left ventricular hypertrophy. Take a look at the CCG. What do you notice about the axis and QRS complexes over the left ventricle, V5, V6, and right ventricle, V1, V2? The deep S waves seen in the leads over the right ventricle are created because heart is depolarizing left, superior and posterior, away from leads V1, V2. There is left axis deviation, positive in I, negative in II, and there are tall I waves in V5, V6 and deep S waves in V1, V2. Left ventricular hypertrophy. To diagnose LVH you can use the following criteria. R in V5, or V6, plus S in V1, or V2, greater than 35 mm, or AVLAR greater than 13 mm. S equals 13 mm. There are several other criteria for the diagnosis of LVH. R equals 25 mm. A common cause of LVH is hypertension. Bundle branch blocks. So, conduction in the bundle branches and Purkinje fibers are seen as the QRS complex on the ECG. Right BBB. Therefore, a conduction block of the bundle branches would be reflected as a change in the QRS complex. Bundle branch blocks. With bundle branch blocks you will see two changes on the ECG. QRS complex widens, greater than 0.12 seconds. QRS morphology changes, varies depending on ECG lead, and if it is a right versus left bundle branch block. Right bundle branch blocks. What QRS morphology is characteristic? For RBBB the wide QRS complex assumes a unique, virtually diagnostic shape in those leads overlying the right ventricle, V1 and V2. Rabbit ears. V1. RBBB. Left bundle branch blocks. What QRS morphology is characteristic? For LBBB the wide QRS complex assumes a characteristic change in shape in those leads opposite the left ventricle, right ventricular leads, V1 and V2. Broad, deep S waves. Normal. Hypokalemia. Hypokalemia. Severe hypokalemia. 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 Hypocalcemia. Hypocalcemia. Acute pericarditis. Acute pericarditis. Cardiac tamponade. Pericardial effusion electrical alterance. Hypothermia Osborn wave.